We've been asked just to provide, sorry, I just had a Heath bar crunch and it's sticking in my throat. By the way, there is candy up here if anybody needs a little bit of an energy boost. I've been asked to just provide a couple of introductory remarks to kick things off. And just wanted to briefly say that this is a topic that the mHealth Working Group based here in D.C., which you will hear about in a couple of minutes, has been talking about for a long time. It's a series of topics that all of you have also been talking about, I'm sure, as well. And it's, fora like this that allow us to come together and identify common problems and work on, creating common solutions to those problems. And so I'm very happy that you're going to have an opportunity to talk together about these things. Let me just go ahead and quickly introduce your co-chairs for the event. So we have Laura Rainey sitting over here, and we have Kelly Kiesling here, and the two of them are the co-chairs of the mHealth Working Group. And today they're going to be talking to you about the working group, how you can contribute to the work of that group, and some of the common barriers and potential common solutions that USAID is very interested in, and some of our implementing partners are working on, for instance, in developing an implementation guide, a series of guidebooks to help all of us learn from past successes and failures and incorporate them into our future work. And I'm sorry, I'm going to have to step out, but I think you're in good hands. Take care. Thanks a lot.
Thank you.
It's down there.
Yeah. Is this mic working?
Yeah.
Yeah. I want to thank you all for coming, especially what's been a long and exciting and grueling mHealth Summit. And we appreciate you taking the opportunity to have more of an interactive discussion here. And for those of you that are new to the mHealth Working Group, we were founded in 2009 by global health organizations for global health organizations to help with their successful use of mHealth within their projects around the world. In particular, we're as a collaborative forum for global health organizations to build their shared knowledge, promising practices, capacity around a broad range of mHealth issues, specifically in developing countries. We're probably most familiar with the work that we do, holding monthly meetings largely here in Washington, D.C., and that we distribute through our listserv to over 800 members at over 200 organizations in over 45 countries. And so we encourage you to keep up with that if you are currently on the listserv, or to join if you haven't, and the results of this meeting will certainly be distributed to that. But I'm very glad to have you here, and I'll turn you over to Laura Rainey, my co-chair, to discuss a little bit more about today's event.
Okay. Thank you so much. We're going to be a little unusual. We're going to get you up moving. So the first thing that I'm going to have you think about, and I'm going to come pass out index cards, and so everyone can get a chance to interact with everyone. We want you to write down one thing legibly in very neat handwriting, because you're not going to be reading it, someone else is going to be reading it. One thing that either you've heard about or that you would like to learn more about in mHealth that would help you in your work. So think about that. I'm going to pass these around. What we're going to do, we're going to exchange cards, and then you're going to write your own score on it from 1 to 5. The other person doesn't need to see your score. So if you think it's a great idea and it's very applicable to you, you give it a 5. If it's, you can give it a 3. The lowest is a 1. So what we're going to end up with, we're going to keep rotating, exchanging cards till you have a card that has 5 numbers on it. If you have more than that, it's okay. So you're going to have one card, 5 numbers on the back, and then I'm going to ask you to add them up. The highest score your card could get is a 25, and those will be the really hot topics. So then we're going to see what those are. After this exercise, we are going to turn it over to Kelly Lingle for a presentation on the mHealth implementation guide that she and her colleagues have been working on, and then we're going to break down into small discussion groups to talk about planning and design, technological considerations, scale up, sustainability, and evaluation. And you can self-select in the group you want to. So right now, just to get up and move around, I'm going to pass out these and think of one thing that you'd like to learn more about that would help you in your work. Okay, for those of you who just came in, what we're doing is an unorthodox exercise. If you can think about for one moment what you would like to learn a little bit more about that would help you in your job, write it legibly on a piece of paper, index card, and we're going to swap cards in just a moment. And you're going to score the card 1 to 5. You don't need to say anything too personal like if you're writing in front of anyone. Give the 1, take note. If it really resonates with you, you give the 5. And then you just swap cards. You give that card to someone else. You don't have to exchange a word. Score it. And you're going to pair up until you have 5 numbers on the back of your cards. Yes?
So when you say something that would help us with our job, do you mean like something tangible, or is it a discussion around which
Either one.
okay.
You don't need to use them. Yeah, it could be. It could be anything. Just what is important to you at this point on Wednesday afternoon at 1:45. Does anybody need more cards? Okay, just a minute, we're gonna. Okay, people need 1 more minute? Yes. Do write legibly to your friends and colleagues and read what you've written. Just keep the chocolate here on the floor and clean it. Okay, in time paper. Okay. Let's go. Everybody stand up. Give your card to a neighbor, someone else, but everybody stand up and then take their card and give it to someone else. Give your card and then take their card, and you put a number on the back of it. And then hand it to someone new. And hand it to someone new.
I'm doing it.
It's nice. Yeah. So 5 is great. 1 is not so great.
Don't give everyone 5. That doesn't help.
Does anybody need paper and pen? No, you score it on the back so people can't see your score.
Once you have 5 scores, take it out. Back up.
Okay, when you have 5 numbers on the back of your card, stop. Does everybody have 5 numbers on the back of your card? Okay, keep going. Yeah. Okay, so when you have 5 scores on the back of your card, go ahead and add that up, and go ahead and turn them back in. We switched it a little bit. Yeah.
Busy day for you?
Then we'll let you take it. Yeah, exactly. And I'll just take our names. So yeah.
Yeah, God, it's probably the first one they've ever gotten up in, right? I come every day, but only per card. So like the first day, I somehow didn't know that the luncheon was Monday. I thought it was Tuesday. So I was down in the exhibit hall. I came up here like right at the end. Tuesday I came, and then today I just got here. So how's IDP going? I didn't go to it. We had a budget. We had to give a budget presentation. I had to do that. So I feel bad about IDP, but it happened. Hi, everybody. My name is Peggy Diadamo, and I'm here to introduce Kelly Lengel. But before I do that, I just wanted to say a little bit about myself and why I'm here. I'm the technical advisor at USAID to a project called Knowledge for Health. And my interest, in addition to mHealth and other things, my real passion is knowledge management. And I think it's really important to create mechanisms for sharing knowledge and information about a lot of things. And my particular project's focus is family planning and reproductive health. But they also have worked on kind of creating knowledge sharing activities and resources for HIV/AIDS projects and and in some cases for partners who are collaborating across the realm of health in the field. So my project supports a lot of different things, including the mHealth Working Group and also the work that Kelly and her team are doing to create this implementation guide. And that's why it says family planning, because since we're a family planning focused project, we wanted to focus our energies on family planning. But I do think that a lot of what she's come up with, and they will be coming up with as we move forward on this, isn't just applicable to family planning. I think it could be applicable kind of across the board in health. And I really appreciate the work that everybody's doing on this. And with that, I would like to introduce Kelly Lengel, who works for FHI 360 and who I met several years ago through mHealth. And in addition to working on this activity, she's worked on a very interesting activity that FHI itself has implemented in Tanzania, Kenya, and now a couple of other places called M for RH, or Mobiles for Reproductive Health. So she may tell you a little bit about that as well as this. Thank you.
Hi, everybody. So I'm not going to spend that long talking because this is an interactive session and we've all been to a lot of sessions and heard a lot of other people talk, and the goal today is really to give everyone a chance to get together and learn from your peers. So I'm a behavioral scientist at FHI 360, and so my interest in mHealth has really come from my background in health communication and how can we use mobile phones to really reach underserved people, behavior change communication, how can we best support community health workers, et cetera, et cetera. But we've really been privileged to have support from USAID to help create some global guidance documents. And so Peggy referred to one, so did Adam Sloat. And so we're actually creating an mHealth implementation guide with support from USAID. And this is going to be a web-based resource that it will be a living, breathing document that we hope is a highly collaborative and co-branded kind of effort with our good colleagues. But before we did that, we actually created something called a high impact practices brief for USAID. And mHealth for family planning, it's not yet a high impact practice because we don't have enough evidence, so we call it an emerging practice. And so that was kind of the first lens that we approached mHealth implementation within, is what are kind of best practices that we know at this point for implementing family planning and reproductive health programs. And as Peggy just said, really what we've pulled out really has relevance across it's kind of content agnostic. It doesn't matter if it's family planning or if it's reproductive health or if it's malaria, or it really, we're finding that these lessons that people are learning really have applicability across your content, your health or development content area. So you don't need to take notes on my presentation because we're actually going to distribute this first draft of the high impact practices brief. And so just about everything that I'm going to very briefly talk about is in this brief, okay? And I'm going to go through a little bit on the evidence. I'm not going to spend very long on it, but just to highlight some key articles that you may want to actually look at to help guide your work. And all of that stuff will be in this brief. And so, you know, you don't need to note take. So I love this quote: everything depends upon execution. Having just a vision is no solution. That vision is, of course, really important, and I saw a lot of the note cards were about logic frameworks and models and M&E plans and things like that. So, you know, visions are really, really helpful, but execution is so important. So, you know, when we look at mobile phone penetration, I think this table is really interesting because essentially we can kind of look at it and say, okay, we're kind of reaching saturation with mobile phone penetration in higher income developed countries, and yet the growth in our emerging markets, our middle and low income countries around mobile phone penetration just continues to be absolutely phenomenal. So this is from the World Bank and the International Telecommunication Union from 2012. So, but it's really illustrative, I think. So one lens that I look at mHealth in is through kind of a first generation and second generation kind of projects, right? And so this is a slide that's from the GSMA from 2012, and it's so illustrative. And I'm sure many of you in this room have really seen the slide. You're knowledgeable about it. But essentially, when we think about our mHealth programs, when we think about these first generation of mHealth programs, we really have gotten evidence on usability and acceptability, but not very much on impact, right? And so this first generation kind of research around it is predominantly focused on demonstrating that the technology for mobile health works from a technical perspective, and that end users really like mobile health solutions. And it's really, really valuable. And we've done this. We've established it, not 100% across the board and not for every individual project, but in general, it pretty well kind of works. So when we go into our second generation projects, sorry, hold on 1 second, I'm working on my notes here. So we go into second generation projects, and excuse this kind of messy graphic, and I actually think it's dated now too, which will be nice to update it after this meeting. But our first generation projects were more about single function mHealth programs, kind of siloed, kind of fragmented. We didn't use the data. We don't use the data that we collect to really filter that up through the health system. Data collection is often thought of as a burden that detracts from the time spent delivering services, not a lot of integration of services. As we move into these second generation mHealth programs, which is where, from my perspective, this is where we're moving, we're really using that health encounter data to inform policy and also to improve care at the point of service, right? And mobile devices are increasingly becoming and will continue to become key in our health information systems. One device is going to have multiple functions, as we're hearing a lot about that in this meeting, and devices will be able to communicate with each other and numerous data systems. And so we're really moving towards greater scope, greater scale, and greater sophistication. So kind of the Swiss Army cell phone. So that just helps me in thinking about where we are and where we're going to head to. Now, when we try to look at categories of mHealth programs, and I know that a number of different and really smart partners are working on kind of taxonomies of mHealth programs, and I've come to the conclusion that it doesn't matter all that much. You need taxonomies because it can be helpful in knowing how to move forward. But there's a lot of different ways to kind of divide the different uses of mHealth. And so we've kind of just hit on this kind of dichotomy. And it's very broad, and it's essentially our client-centered programs and our health system strengthening healthcare provider programs. And I've seen other frameworks. The WHO and mHealth Alliance are working on a framework that splits them a little bit differently. We saw one from the PMTCT framework that splits them a little bit. So there's different ways to divide them. And for our family planning programs that we've been trying to look at, this is pretty much what we've come up with. So client-centered, we have two examples from the family planning community. So Mobile for Reproductive Health, that's the program that Peggy just mentioned. So I lead that program with my colleague Heather Vidot, who's also here from FHI 360. And essentially, it's an SMS program, and it's at scale in Kenya and Tanzania, and it's newly being implemented in Rwanda. And it's a menu-based, entirely SMS-based system. And you can choose to get SMS information about 9 different family planning messages and family planning methods, and each method has 2 screens of content. And we also have a searchable database of clinic locations. So it's actually a very simple program, and we're scaling that up with Johns Hopkins in Tanzania, and it's been really exciting, and we have lots of neat lessons learned from that. So CycleTel is another program that you may be familiar with, and that is using smartphones to support the standard days method, so an actual women or couples use of the standard days method. And then for health system strengthening, at least within the family planning community, we have the ComCare platform, which I assume many of you in this room are also familiar with. It's point of care support, counseling guidelines for community health workers. We're currently working on a project in collaboration with G-Tree that's creating a family planning module for the ComCare platform in Tanzania. And then the ILS Gateway is also a really great family planning commodity-focused project that JSI is also running in Tanzania. So Impact of mHealth. So I want to breeze through these slides, but I also want to acknowledge that, in the sessions that I've been to, and granted, I haven't been able to go to that many sessions, but we're talking a lot about the lack of mHealth evidence and different frameworks and approaches, and what type of, should we use RCTs or should we use more operations, research design, et cetera, et cetera. But so what we've really tried to do is to hone in on what is the relevant evidence from peer-reviewed publications, and I say that with a caveat because we know that peer-reviewed publications really just look at a certain segment of our evidence base, and just to look at them starting with family planning. But again, this definitely has, what we've learned here has relevance for our other health and development areas that we're using mobile phones for support. So when you look at the evidence on the client-centered programs, so we have good evidence and we have some kind of systematic reviews that text message programs are effective for behavior change. There are different issues, so things that folks have identified: access to and sharing of phones, language issues, literacy, technology challenges. We need more information on best practices for developing content and also the dose and frequency of delivering our behavior change communication messages. There's new issues around how do you best present educational information for your community health workers or like health advisors. And then when we look at the evidence on health system strengthening, this we have much less evidence on for a couple of different reasons, but when we look at it, we see we're starting to get some really nice evidence coming out that health worker reminders about protocol guidelines result in better treatment compliance, and that's really, really important, and that's really, really exciting. So we can also use mHealth for supply chain management and more efficient delivery of community health services. A number of different issues, things like how do we encourage healthcare providers to use these tools? I think we've heard a lot of that at this meeting. And how do we better link these tools to health information systems? I'm really going to just breeze through this really quickly. Again, these are cited in the brief, which we'll pass out, but just for you to see them. So what kind of peer-reviewed evidence do we have on mHealth for family planning? So we have the Knowledge for Health program in Malawi that's comparing having phones, community health workers having phones versus not having phones. SMS is cheaper and it's more efficient. We have the program that I talked about, Mobile for Reproductive Health in Tanzania, and we have data that family planning information can feasibly be delivered via mobile phone, and that you're able to reach underserved populations. They're actually going to access family planning information via mobile, such as men, rural populations, et cetera, adolescents. That's really important. We have the study that is from the U.S. about SMS reminders for continuation of daily pills or oral contraceptive pills can be effective at increasing adherence. And then we also kind of bridge out a little bit because there's so little peer-reviewed evidence in family planning. And so these are some of the other studies that we've identified that we think are particularly relevant for family planning in the broader field of reproductive health. So just very quickly, Sex Info in the USA, that was an SMS-based program. Really, we feel like we're standing on the legs of that program a lot. It's a really innovative program, and we're all building on it. We have our data coming out of Kenya that ARV adherence to HIV medications can be improved by 10 to 15% when we use these randomized controlled trials, right, compared to standard of care. Wired Mothers in Zanzibar, SMS reminders for skilled delivery attendants at births. And then the last one I have in here is really about malaria case management. There was that excellent article that I think was in Lancet that came out of Kenya that was really exciting. And then just a few more mobile rich media job aids for community health workers coming out of Colombia. The SMS for Life program in Tanzania was able to reduce stockouts of antimalarials, and then some really neat research about what can we do with peer health workers around HIV in rural Uganda. All right, so I'm going to move on. I'm sorry, I have one more slide just about research. So we've, in looking kind of at the evidence that's out there, we've really identified 4 main areas where we really need evidence about the effect of mHealth. Now, I know Bill Philbrook working with or with support from the mHealth Alliance, has also done this wonderful analysis and has identified 8 gaps, evidence gaps, and those are awesome, but I'm just going to show these are the 4 that we've kind of hit on. We need evidence for impact of mHealth on clinical and behavioral outcomes, cost effectiveness and cost benefits of mHealth tools, the influence of mHealth on the wider healthcare system, particularly at scale, and then conditions for and enablers of successful scale-up of mHealth. And we've heard some about, at this meeting, about some of these topics. We've heard less about others. The chart is from GSMA 2012, and our evidence is skyrocketing, which is really nice because we all need that guidance. So to transition into what we really want to talk about today, or really what we want to really hear from you all about and give you a chance to interact with your peers around, is what are kind of our main considerations for implementing mHealth? And so what we did was we noticed through the mHealth working group and through our work with them, we really noticed this gap in we need guidance for how do we best implement these programs. And so we started by looking at the published and the gray literature. We conducted interviews with 18 mHealth experts, with family planning kind of being our seed, but we actually broadened outside of that. And so what we did was we did those interviews, we did these desk reviews, and we took what we learned and we organized it according to 5 different areas of mHealth implementation. So we have planning and design, technological considerations, scale-up, sustainability, and evaluation. And what we're going to do is we're going to transition. I'm just going to go through these really quickly. But what we did was to come up with what are kind of the main considerations. And we framed these as questions initially, although that format may change as we actually take this information and use it to create this mHealth implementation guide. And again, these are all in this brief we'll hand out. So first of all, mHealth planning and design. Our goal here is to determine if the proposed mHealth solution is appropriate for the context, right? So we have a number of different questions here. I'm not going to read them out loud because you can read them. And one thing as I'm talking that this brings up is kind of who is the audience for this? And it's a really good question. And essentially, we all need this. So implementers need some guidance, and donors need guidance in reviewing proposals, and governments and ministries need guidance in what's an effective use of their scarce resources. And so we've kind of tried to frame these as questions for these different audiences as they're designing, scaling up, putting resources in, making decisions about programs. So our second one is technology considerations, and so here the goal is to determine how the proposed project will work with existing technologies, infrastructure, and capacity. And these, again, are some of the main kind of lessons that are coming out of these interviews with these mHealth implementers and also our desk review. So scaling up in health is the third broad category. And essentially, it's determining the project's potential for scale-up. We've heard a lot about scale-up at this meeting because it's something that we're all highly challenged by. And as you'll notice, as you read through these, there is redundancy across the categories. So hopefully we'll be able to reduce that at some point, but recognition that each area of a program influences another area. The fourth category is sustainability of mHealth, and the goal here is to consider the accessibility of resources for the long-term operation of the project. We've also heard a lot about that at this meeting, so some really good ideas and good guidance has been put out. And then the last category is evaluation of mHealth. It's really important to assess the potential contribution of the evidence generated by this project. So this would be kind of specific to a project that's newly being implemented or that's being considered to develop. So the evidence is, of course, important. What we know and what we don't know is important across these 5 topics of mHealth implementation. And so just this 5th one of evaluation as it's framed here is really kind of project specific. Okay. So that's pretty much kind of the information that we wanted to share with you all. And should we do roundtables or should we do vote? Okay. So we're going to get up again. And let me find the right thing. Okay. Okay, so we're going to do like a 10-minute kind of exercise, right? And we really are hoping that this session today interact with your peers. Let's process what we've all been hearing about. So we're going to do a quick little exercise called Vote with Your Feet, and after that, we're going to kind of do our roundtable discussions without our actual tables. The Vote with Your Feet, we have a question. Oh, wait, I don't have the wrong question. Okay, here we go. We're going to start with the money question. Should mHealth users pay for this service? Okay, so we want everyone to get up, and I think, where should we put everyone? On that side and that side? Okay, so if you think that mHealth users should pay for the service, then how about you stand over here? And if you think that mHealth users should not pay for services, stand over there. Yes, Ms. Reed. Sure.
You maybe define who is the user. We're talking about client.
Yeah, think of client-centered programs, okay? No, not a health worker, right? You're targeting,
General population.
no, sorry. Look only at the one that says money.
Should we do a spiel and then?
Yes, so we have our plants in the audience. So this is Pam Riley from Apt Associates, and Kelly Kiesling you've been introduced to. So Pam's going to tell us why she thinks that the end user of, let's say, an MBCC, a behavior change program, should be paying for the information they're accessing via mobile. And then Kelly is going to share with us why he thinks they should not pay. Okay? You bet. Then come up here.
Okay. So, this is a 1-minute sell, and it is to say that there are 3 reasons why end users should pay for life-saving health information. Number 1 is that mobile phones are inherently a commercial product, right? They have made it into all of these communities without one dime of donor funding. And by charging for the content, you have an ideal way to measure its value. If those messages are free, they may continue to get them forever, but they're actually not paying attention to them. If they're paying for them, you know that it's something they value. Number 2, when you pay for content, as a consumer, you now have the attention of the mobile phone operator. Oh, I mean, there's revenue here, and now you've unleashed the marketing arm of the mobile phone company, the most powerful marketers in a country, and you can get to scale. And then number 3, the reason that you want to start out with a paid service is over time, if you see there is no willingness to pay, you can always start making the price lower. You can maybe add some subsidized services for the poorest that could be subsidized by the wealthier. But the fact is, if you start out free, you're kind of stuck there.
So if you're with Pam, you go to that side of the room. Counterpoint is, the reason not to charge users, and by that I mean client users, patients, and general population, for use of mHealth, is that studies have shown that it is a barrier to the adoption of mHealth and the sustained use of mHealth. In particular, introducing costs can bias use towards those that are wealthier and act as a barrier, in particular to the poorest of the poor, the most vulnerable populations. Even if they have access to phones because they spend part of their wallet on that, part of their income, what you are in effect is taking even more money from their income to spend not only the money they spend on the phone, but to spend on how to access health information through that phone, further reducing the amount of funds that they have for taking care of their own well-being. And so for these reasons of it acting as a barrier, and in, serving as a bias against those that don't have the financial wherewithal or don't have control over their own finances, such as women in many situations, this may not be helpful for mHealth. So if you agree with that, come to me to this side of the room.
on the fence. You have to choose. Oh, you have to choose. You can't be in the middle. You can. Nope. No. Hello? Okay, so. Is that microphone long enough? Can't be in the middle. You gotta choose. Oh, okay. So should we do that? I'll put it back. Hello? Can we move it? Is that okay? Hamish, calling you out. Hey. But why do you agree with Kelly? Why should you agree with
Well, because we know that there are so many barriers of access to care, and cost is very clearly one of them. And we know from access to health facilities, for example, that if you take away user fees, you hugely increase the access to care from the most vulnerable populations. So I think that any situation where you're starting to charge people for something which we think is valuable for their health has to be treated with great care.
Does anyone have anything else different from this group that they want to add, a different perspective about why you think it's important that users not pay for these services?
This is kind of an old argument, but I think that information wants to be free. There's no real cost to duplicating a piece of information that already exists. So to attach some kind of a cost onto that feels kind of false. Not to say that there's no cost in sending a message, but I think that just scaling up a message shouldn't cost any extra information. So I don't think the right solution is to make users pay for that copying.
If I may add, simple text messages, I don't think they should be charged because, other, even in the commercial sector, they use that to let you know about their sales, for example. They don't charge you for that. You can choose not to read it, but you might want to take advantage and go and save 10%, right? So, but maybe if they were using more, like deepening their access to the information, especially speaking with somebody on the phone or getting maybe more customized advice for their need, perhaps there could be a little charge, some charge, but we don't really believe that source text messages about, immunization data of their child, they should be charged for it.
Well, just a quick add. Since we nationally were moving towards access, free health care to all, so I think that this would be in tandem with that as well. But also, most health insurers already provide some type of free health information, so why would you want to charge additional for these type of services as well?
So it sounds like you were talking about sort of like a freemium economy, where you give your content free, and if you want to add on things, you charge for that. You were making what I would call the social justice argument, that there's barriers and you should never have those barriers. I think that there's also the social entrepreneurship model, where there needs to be some different innovative ways of thinking about how can you pass on the costs or create a system where different parties are all mutually benefiting. So there's Project M in South Africa. There's other models that you could probably scale up that would potentially meet somewhere in the middle here.
Yep. I do have another argument to add as well. One of the things I keep hearing is that there are opportunities for mobile network operators to pay for services. And while I do think to some extent that may be true, it seems like when you actually look at these numbers, if our bottom line is increasing access to services, and information for people who don't already have those services, those people have not been very appealing to businesses because they really don't have money. And there are people, I'm not entirely in this category, I just kind of tend over this way, because there are people that can pay for services. But in the places I'm interested in working, those are a much smaller share of the population than they are here in the US. So anyway, that's another argument I just wanted to add to you. Any more?
So is anyone persuaded? Does anyone want to switch sides?
And not to spoil the. I think we should also think, there may be instances where it makes sense to have a revenue model, and other instances where it makes sense to have it provided for free. So you have to take into account.
Can we turn off this microphone, please?
Oh, you can hear me all? Can you hear me? Hello? Hello?
This is, can you hear me? Okay, no. Hi, can you hear me? Okay, so this is not, this is not a pro or con for or not people pay, but because this is the mHealth working group, I just want to make sure that we're all clear on what we're talking about, because I think we should be careful about using the term mHealth to just talk about behavior change, which is what this conversation is about. This is about getting information about services or getting information about health. But there's a lot of other mHealth out there that is not BCC related. For example, JSI works in mHealth for supply chain. Other people are working in mHealth for follow-up appointments for PMTCT or that kind of thing. And so when we talk about should people pay for mHealth, we're not going to expect that the facility worker that we are asking to provide us with information on their stock levels should pay for that. But if we're talking about maybe people paying for information about, health services, then maybe that's something that we want to think about asking people to pay for. I'm actually on the fence about that, but my point is the larger point, which is can we make sure we know what we're talking about when we use the term mHealth, and try to avoid using the term mHealth to apply to specialized pieces of mHealth, and when we're talking about a specific type of mHealth, to make sure that we're clear about what it is that we're talking about. Thanks.
Hi. Operators are in the field to make money. If we see so many projects in Africa and fairly little in Asia, does it sound weird? Because technology is really on the Asian side. But why Africa? It's a second market. That's where the market is going to expand. That's where all operators are going to make money. So let's take advantage of that and have them on our side. And I agree, depending on the type of service, the type of project, when you set up your project, you need to work and to get a contract with your operator. So the cost of each communication can be lowered, either at the client level, either at the organization level, depending. Look at what the Grameen Foundation has been doing. And I guess if you don't have a business model behind you, and you work on free, subsidized, you are not going to do any market test. You'll never know if your application or your program is getting some impact.
I'd like to refute, not refute, but respond to the knowledge or information wants to be free. I'm standing on my tiptoes and looking at Mike back there. I think information does want to be free and should be free, but the challenge is that access to that information is not free. So I'm thinking, when we talk about paying for services, or having free services on the other side of that. It's often, zero-rated services, right? So you don't pay to send a text message, for example. Or we zero-rate a certain web address, which means that if you visit that in your browser, you don't pay for the data that gets exchanged when you connect to that site, like Facebook had Facebook Zero. So in my mind, I wasn't thinking that we would be charging, say, for the information, but I think people should be paying for the connectivity, that access to the information. They already are, in fact, right? So I don't think that we couldn't imagine that we would charge someone to send an SMS if they wanted to send it, but still provide the information that they receive essentially for free. I don't see there's a paradox there.
I also think a big issue is accountability. If a patient is paying for the data, you are accountable to them and their needs. If it's being given them completely for free and it's paid by a donor, you're accountable to the donor. So we all like to say, of course, no, we want to ask the patients what they actually want, but if at the end your donor says, no, I only want to provide this type of information, you're going to do what the money tells you to do. But if the patients are paying you and the patients say, well, we want this type of information, then you have this obligation to respond to them, and you will respond to them. So I think in the end, you'll actually be providing them with better, more useful information.
It's unfortunate that there isn't any middle ground there, because I'm also on the middle ground. Yeah, but then this question is very interesting and very close to home for me, because I actually work with Kelly on M4H in Tanzania, and we've gone to scale, and we've actually had this question with us all the time. But yes, we have to give access to the most vulnerable, to the most hard to reach, but we also have to be realistic. The places where we work in, they don't have, the governments are not going to take this over. So where are we going to get the money to pay for that? But at the same time, like another colleague here said, the mobile phone companies are going to these countries more and more. Why? They're making a profit. So people are increasingly being able to afford for these services. So I'm not saying that we should charge maybe one-on-one, but maybe we could develop a payment structure whereby we can create subsidies in a way for low-income populations. But there are people who can pay, so why are we paying for people who can pay? Sorry. Yeah, like myself and many, many other people. Yeah. I think that was the point.
I just wanted to make a point, and first of all, I think we need to have a discussion about, well, why isn't the government willing to pick some of this up? Because, in fact, this is their population, and they need to really, they need to pay attention to that. But the other thing that's a little dicey is if you subsidize through payments from people who can afford it, you end up having the red-blue situation that we have in this country, which is where people who have the money, or some people who have the money, are thinking, why should I help people who aren't taking care of themselves? And it's actually a sad state of affairs. But that, I think, depending on your model, can drive that. So just being aware of that, I think, is important.
Could I make a qualifying remark, having been the first person to speak? So I wouldn't quite make it to the middle there, but I think that it's important to make a distinction between whether we are dealing directly with patients and clients, or whether we're dealing with some aspect of the health system more internally. Because, for example, if you're looking at improving drug supply chain, it makes total sense for the cost of the SMS service to be baked into that, because you can save a bucket load of money by not having stock outs, by not making last-minute purchases. So it's definitely part of the cost of doing business. I think that, to me, I was addressing very much a patient in the community and whether they should pay directly for that.
I would like to respond to the user. I mean, there is a lot of evidence showing that people, even the poorest ones, prefer to pay for their health care. And so the issue of not paying for a service doesn't make sense.
Not in Europe, or in Haiti, or whatever.
The middle.
In the middle. Is it yes, so one service this class need a cost back.
It is ultimately sustainability.
Yes.
Somebody's going to have to pay for it in the end. So I think we have to figure out some models.
The parent program. I was looking for you. Excuse me, my English. But people pay in some countries for service, health service. In Eastern Mexico, for example.
Yes, Christine has the
last
word. Can you notice that there are 3 African ladies on this side of the room? Does that tell you something?
Okay. Yes. Okay. So let's do we have the results of the introduction activity? Have we ranked what came up first? Do we have that? Where's Laura? Laura. Yes.
Can we do this quick, or should we? Yeah, we can do this quick.
Because then we're going to gather into round tables.
Okay, so sharing results of what worked and what didn't work with regard to using mHealth content in the field. I'm reading the 20, this was a 23. How can I design my mHealth intervention so that it answers the question, does this mHealth intervention provide added value to this program? Another 23. What are the top 10 most common issues that come up in the early stages of program implementation? And basic troubleshooting tips for dealing with them. This is a 22. Remember, the top score was 25. Logic models, theories of change for M&E of mHealth interventions. Don't have my glasses. How to effectively evaluate an mHealth project. Definitely keeps coming up. How to get mHealth and ICT for Health viewed internally as strategic and not just an add-on tool. Very helpful. 21, so we're still in the upper numbers. One place that I can find mobile health initiatives that have already been piloted and could be scaled up. Some examples of successfully scaled up and sustainable public-private partnerships in mHealth, still in the 21s. How do we promote integration into health systems and across health areas for mHealth? Health impact of MBCC, better tools for testing and quality assurance, we're still in the 20s. How do we bring mHealth technology to scale in resource-limited settings? Who pays for the maintenance of the technology, such as SMS, smartphones, etc.? Which mHealth learning tools and approaches work best in low resource settings? So those were the top ones from the exercise that you did. Thank you. No.
So that was actually really interesting. So what we're going to do now is we're going to break up into roundtables without the tables. And so what we'd like to give everyone an opportunity to do is actually, sorry, I'm going to go back for a second, is to join someone standing in front of our slide projector. Sorry. So we want to give everyone an opportunity to talk with your peers and colleagues. And what we're going to ask you to do is to choose one of the 5 topics here that you'd like to spend a little bit more time talking with your colleagues about, right? And okay, so let us do planning and design. Yes, so James Montempo, if you want to talk about planning and design, and here, let me actually go back and show you kind of the questions that we have around planning and design. Then please go with James Montempo over there. Okay, our second category is technological considerations. And if over here, Heather Vedat and Hayo, is Hayo still here? Okay, so with Heather Vedat, technological considerations, these are some of the questions for this particular group. Our third topic is scale up, and Kelly Kiesling is going to lead that over here. Okay. Our fourth topic is sustainability of mHealth, and Pam is going to lead that. Sure. Sustainability in the back, and then our last category is evaluation, and I'm supposed to lead that. So, and why don't we do that? Where do we do it? So, kind of in the middle there, I guess. Okay. And here's go kind of find your group you want to talk with. Okay. So, planning and design, technological considerations, sustainability. Scale up here.
Yeah, scale up here.
Is that right?
Right. And real quick, for the facilitators and note takers, Pam, for facilitators and note takers, can you pass around a piece of paper getting people's names and their emails so that we can send them the follow-up information, and then label it with which roundtable topic that is?
Hey. So where's our evaluation group? I'm supposed to say the evaluation group. So where's the evaluation? If you want to talk about evaluation, can you raise your hand? So kind of in the middle. So let's just kind of sit in the middle there. Okay. And if you can kind of move the chairs, okay? We have this room, so move the chairs into a circle. All right, for your group. And I'm going to talk just for a second while everyone's getting set up. So planning and design, technological considerations, scale up, sustainability is in the back, and evaluation is in the middle. And what we've done is to give you guys, we're going to leave these up on the slide projector, is to kind of give you some questions to kind of help your discussion. And one of the things that's really important, in addition to learning from your peers, is what are it's C up here, what are the tools and resources that you're finding are helpful for this area and that you feel like are lacking in the area that you're talking about, okay? Because we are putting together this mHealth implementation guide, and as part of that, we want to be able to identify missing tools and resources. We want to be able to identify gaps that the mHealth community really needs to more effectively implement our programs, okay? So I would just encourage everyone to, try and get to that place, and I think we're going to have about 30 minutes of discussion, 20 minutes of discussion. Does that sound about right? Good. And Reed, can you be in the evaluation group? You're leaving? Never mind. Okay, that's fine. I'm going to come over. We're coming. Because I was going to try and do something else.
It's because I think I probably need to report back. I don't want to okay.
Laura, should we pass out the hip breathe and people can use those questions? All right.
going to give you just a couple more minutes to wrap up, like 3 more minutes. As you wrap up, make sure you designate someone who's going to report back. And when you're finished, there's food in the back. As you wrap up, make sure you designate someone to report back. And there's food in the back. We're going to take about a 15-minute break to let you socialize, and then we'll come back together. We'll meet back at 5 till 4. 3:55. Good luck. 40. Oh. 40.
People are,
worried about it doubling.
Testing. Testing. Oops, okay, so they're going to have to report out this one. Let me know. That's okay. We still have 5 more minutes. So gather your drinks and your food. We're going to start in another minute or two, and we're going to have the report outs. That's okay. Okay, I think we're almost ready to get started. Do I have to whistle? Shall I whistle? Thank you so much. So grab your coffee, grab your water, head towards back here. Thank you so much for coming and for staying. We know it's a really long day. I'm really excited and energized by the discussions that y'all have had. I've been wandering around between the groups. I just wanted to mention a couple things as we're getting back. If you did not get a copy of the draft high impact brief and would like a copy, sign up or give me your card and I'll make sure you get an e-copy, because I only had 75 copies printed and I think they're gone. Oh good, Pam has some. I was going to say if there are any left, please let us know. Okay, Pam, raise your hand and Pam will be kind. The second thing, if you are not a member of the mHealth Working Group, I would encourage you to sign up. Just go to www.mhealthworkinggroup.org. It's on the About page. Literally, you just put your name, your email address. We're not selling anything. We don't have an agenda. We just want to share information across groups. We meet every month in Washington. The notes and the presentations are on our website. So with that, I will call up the reporters for the groups, and I'll let you self-select and see who wants to come first. But I'd like to ask you to please come to the podium and speak into the microphone. Angela?
No, it's on. Hi. I'm Angela Nash Mercado. I'm with JHU CCP and the Knowledge for Health Project. And I'm going to report out on the planning and design team. And I have to say, this group is really dynamic. I'm really pleased with all the conversation we had and the breadth of opinions we had. It was a really great discussion. So first up, under experiences and challenges, a lot of people talked about successful projects that used a business plan. So really having a model to move forth with your project. And in particular, the World Bank had some examples, so we're hoping that we can share those in the future. Doing a landscape analysis was critical, looking at what others have done, what works and what has not. This will help you identify good ideas and build on things that have worked already. We've heard this multiple times, but the need to engage all your stakeholders from the very beginning of the process. Looking at barriers and obstacles, systems and policies, really set the context in which you can or cannot do your work. Narrow thinking can be a challenge. Thinking of mHealth only as one approach. Again, there was a big need to engage stakeholders here as well. Capacity gaps came up multiple times. The need to speak multiple languages. This is really a multidisciplinary area, so speaking with the health, the IT folks, we have all, we need to agree on a common taxonomy. Let me see. We have a pretty long list here, but I was told to keep it short. Challenge of people tending to think of mHealth as a silver bullet, so having inflated expectations. Changes often happen very fast, so we need to be aware of interoperability issues. Remember that it's one piece of a bigger system. Think of interoperability at multiple levels. We also talked about a bit of the donor expectations and flexibility, and considering issues about accessibility and capacity gaps from the very beginning. So how to address some of these challenges? We said never design without involving your end users first, and look at the acceptability. Look at models of process improvement, stratify your users into early adopters, have a holistic landscape mentality, look at the total ecosystem. Be agile and continue to learn throughout the process. Something we've heard a lot, start with the evidence. Include your network operators in the planning process. And skipping to the help and resources, we would like to look at the templates, the business models we talked about, and share those with people, maybe talk about them some additionally. PAHO also has a toolkit on how to develop mHealth policies and how to create collaborative groups. And Ana Lucia agreed that she would help us walk through that. So that was the planning team. Thank you. Do we have a volunteer to come up? Or do you want me to call your name? Okay, what about, okay, technology.
Okay, I've been trying to rapidly synthesize. As anyone who knows me, it's hard for me to be succinct, and this was a really fun discussion, I have to say. Even though we were a small group, you all missed out. So, well, that's not true, because we'll share it all. Just a couple of quick things. We're really lucky. We had a representative from the UN Foundation who was focused on energy, so he was able to kind of say, step one, do they have a way to charge hardware, hardware, and different your handsets, your hardware in general. Sorry, I'm repeating myself now. I'm kind of tired. So let's see, what else have we talked about? We talked about, then your next step is when you're thinking about what technology and what hardware in particular you're going to utilize, you want to find efficiencies in that respect. You want to really think critically about what is the maximum that you need, because often the maximum what you need is not that much. And we discussed one of the analogies of the old stoves that were dropped in Africa, years ago, and that's the modern equivalent is the server, and that a lot of times that isn't really necessary. So trying to be efficient from just a volume of hardware that you would bring in, as well as getting back to the energy, using the energy efficient technologies. Again, a lot of this overlaps with other things, but meeting the needs of your users, so knowing the technical literacy or technological literacy of your users. We had a story about someone actually building an early touch screen kind of from rudimentary resources, so that was very cool. Let's see. So then your next step is trying to identify your expertise for getting into the software level. So you've got your hardware identified. And so I think some of us that have been doing this for a little bit longer, there was a lot more kind of grassroots opportunities a couple years ago, but now even some of the smaller companies, the startups, are growing really rapidly. And so one of the challenges we identified with that was that a lot of times if you get on the ground floor with someone like that, you come in and you've either got the people who are technically qualified, but they're engaged with often, we'll call them more lucrative stakeholders. So getting them to pay attention to your small projects is often difficult. So some ways to work around that are to train within the community by engaging just through networking. Just find people who are interested, even if they're not highly trained, that you can do that for them, teach them the programming aspects, which I thought was a really neat idea because it ties into all of our goals of capacity building. But that a lot of times if you even do work with small local companies, which is often a bigger push these days, that you run into growing pains at some point, because if your partner grows rapidly, then you're kind of back at the boat. You're engaged with that person who now is with more lucrative clients who doesn't want to necessarily take too much time with your smaller projects. So we also talked about some of the challenges with regulations, and that having them can be just as challenging as not having them. And then we talked about cases of also retrofitting the different regulations and how that can present even bigger challenges and even lead to stalemates in innovation. And we had talked about that. I had talked about that actually peripherally a couple of times today. I don't know where. I thought I saw Pam a minute ago. But so let's see, what else we talk about. And I'm sorry, I know I'm not quite following this, but we kind of went down our own path of developing here. We had a really innovative partner in our team, Bruce, down there, and he really pushed for business planning, which I think ties into a lot of what our donor-driven work is, landscape analyses, which I know that your group discussed as well. So just knowing what you're putting forward, but I think a lot of us have to do that as part of our budget building. But that one of the challenges around that a lot is getting the data you need to have an accurate representation of what your needs will be, like knowing what the real on-the-ground numbers are with respect to handheld ownership or handheld access, as well as mobile phone penetrations, that there's a gap there. Another constraint that I want to throw out really quickly that hadn't really occurred to me is donor or partner constraints. For instance, if you have a commercial partner that's supporting your work and that they have, like for instance, a specific protocol that they want to follow, and that can be challenging. For instance, like following 3G, is that something that is widely available, or are you just kind of playing a larger role in trying to help expand like that for commercial partners? Trying to see, I think that's the big thing. Getting back one more point about the capacity building, which is interesting. Being able to identify your own staff can be a benefit, but a lot of times what happens is you are working countries and you are presented with the staff that you are to build capacity with. So that is another challenge that you can have, because sometimes those people may not have the actual interest that may have been perceived by their local supervisors. So I think that's kind of it in a nutshell, and I apologize for being all over the map, but it was a really good discussion, so thank you.
Okay. I see Joy coming. No. Okay. Heidi or Carrie or Sarah or Cornelia? Okay. I see Carrie coming. Sustainability.
So my name is Carrie Miller. I work for Catholic Relief Services, and I'm going to try and do a report out on sustainability. But any members of my group, if you missed something that is critically important and you want everyone to know, just jump in. I was actually going to try and save this for last because that's often where sustainability gets put in all of this. But really, it should be first. But planning beat me up here, so I did make it. But that's okay. But I must say, a lot of the points that the planning group brought up were kind of similar to a lot of the issues we discussed in our group. What I'm going to go through now is just some major highlights, not necessarily following this outline, but we'll touch on all of those points. Just starting off with a lot of the challenges. I think many of you are familiar with these. We're often working under very tight donor timelines to pull together what we want to do, but also to get things up and running. They can be 3 to 5 year timelines, and oftentimes if you're starting with certain systems, that just isn't enough time. There's also a variety in these projects, as other people have alluded to, a lot of different stakeholders who have different informational needs. So if your sustainability plan includes it being taken over by Ministry of Health or something like that, they're going to have they tend to have very low risk tolerance. So they're going to want a certain level of proof before they're willing to buy into your concept. So a lot of times developing or getting that impact data for your project isn't something that you can do within a very short time frame. So that's a challenge that many of us are facing. In other cases, there may be people who are just excited and like your idea, so as long as you're coming to them with a good, convincing business case, that can be a good way of getting started and at least getting engagement early on. Another challenge is a push for innovation, which often means that there may be development of sort of one-off, non-interoperable systems. So that's kind of some of the challenges we're dealing with. Some of the ways people have coped with this is to come up with at least 10 different strategies, recognizing that only 2 of them may actually work. And in the process, you will make mistakes, and you must learn from them. And being adaptable and flexible to roll with the punches is really important in this environment. Some of the other things that I liked that came up a little bit earlier in our discussion was some of the solutions people have come up with is bundling service. Pam gave an interesting example with I think it was the Mama case in Bangladesh, where the husbands were typically farmers. They were paying for market information for their crops. But that was bundled with information about pregnancy that helped, that they could use to transmit to their wives. So, and that aspect wasn't paid for. So they were together, but it's of interest to the mobile companies to make sure that that information goes through. Another issue that came up was capacity and trying to figure out where the IT capacity to sustain these programs will come from. A lot of times, since we're in the health field, we assume that's going to be MOH, but as we heard, there may just be one 25-year-old guy who is sitting there manning the department, so that may not be feasible. Are there other ministries who are interested in this type of information, or is there a way of pooling IT resources across Ministry of Finance or population where you can attract some of the best and brightest IT professionals in the area, so that they're able to help provide those IT needs? Others discuss creative internship programs with potentially other companies. So you get the graduates first, and then they're able to move on to the maybe for-profit company, but you at least get high-quality people helping you to implement and sustain your program and give tech support. Make sure to consider the total cost of ownership. Increasingly, there's more tools available to do this. We also had an interesting discussion, open source versus proprietary. And while there's a lot of very interesting open source solutions, a lot of times these are not designed to support very large systems. And sometimes you're not able to get the tech support you need, especially if you need some customization. The developers may just go away, whereas a vendor is beholden to you, and that can sometimes make things go a little bit easier. And in terms of some models that we thought were quite interesting, Switchboard got mentioned. For those of you, that's basically Vodafone got a lot of the nurses and doctors in a particular in Ghana to sign up for a service. They get free calls to one another, so that helps to refer patients from one another. But you also have people who have an income who can pay for the service, so they're using their Vodafone service to call their family and friends. which is good for everybody. So really looking at ways you can align interests of multiple parties is really critical. And then in terms of another valuable resource, mobileactive.org was mentioned, especially for people who are relatively new to this field and want to get connected to others and learn from others' experiences. So anything else, group? Okay, thanks.
Okay, scale up or evaluation. I see evaluation coming.
Hi, my name is Leona Rosenblum. I work with JSI. And we had a really interesting discussion about evaluation. And I think that something probably came up for all of you, but was particularly a common theme throughout our conversation was the fact that mHealth is a component of a larger public health intervention. And so your mHealth, the evaluation of your mHealth project is going to be a part of the evaluation of your greater program. And that means that some of the challenges that we all run across when we're trying to figure out how to evaluate our projects in general are the similar problems that we're running into around mHealth evaluation. So particularly, we talked a good deal about randomized controlled trials versus other more innovative, different, new, less rigorous, or maybe less clean data situations that we might be trying to deal with in terms of evaluating our mHealth projects, and what are some creative ways to get around the fact that we're dealing with a piece of technology that's moving so quickly and changing maybe before you even have time to finish your study. So we were talking about how, and actually my computer just ran out of battery, so I'm going to have to remember what we were talking about, but we were discussing some options around the ways that our interventions themselves are providing the data that we can use to evaluate them, but that raises the question of setting up evaluations around the technology and isolating that aspect, and what we're looking at in terms of the process side of the evaluation. Is this technology succeeding in helping us to meet our goals, and how could it be doing that better, versus how is the technology aspect helping us to achieve, or whether the program is achieving the health outcomes, and looking at maybe how far do you have to go in evaluating achieving those health outcomes. If you already know that there's significant improvement in health outcomes if people come to the clinic for certain services, if you're able to prove that the mHealth evaluation is bringing more people in, do you need to also prove that the mHealth evaluation is improving health outcomes to 10 years down the line, or can you take the information from other evaluations that are being run? Some things that we took away as information or things that would really be helpful moving forward, particularly around evidence, around evaluations that have already happened. So I know everybody sort of brought up landscape analysis in different ways, and we talked about the fact that these initiatives are underway, but that implementers really want to know what has been done, what has been evaluated, what is the evidence, and where are the evidence gaps, so that going forward you know where to plug into that, and really guidelines, step-by-step indicators and sort of manual for things to keep in mind when you're starting out adding an mHealth component to your project, when you're going to need to evaluate it later. So didn't really go exactly in the order, but we had a really great discussion, and hopefully we'll be able to share it with all of you in the notes later on.
So on the issue of scale-up, we had a very interesting discussion, and we're very glad to have a broad mix of participants from the public and private sector, and from staff based in various parts of the world, including local staff in many countries. And we discussed what were some of the main barriers in mHealth and some of the suggested solutions on that. And after discussing a wide array of them and then choosing those that we thought were most unique to mHealth and most soluble, some of the issues brought up were the constant evolution of technology, and that in the scale-up of a program this takes many years, and that it's hard to keep up with the moving target of changing technology, and so you need to build flexibility for technology evolution into your planning, into the implementation of your program. Another is the lack of government buy-in that needs to accompany integration of mHealth systems with health systems and health information systems, and the need for connecting with government champions on this. However, one of the challenges in this is that there's high turnover within ministries, and a solution is to build support for an mHealth project at all levels, including the base of health workers and project managers that you deal with along the way, so that you can deal with the turnover that exists in ministry allies. Another issue is that your target population may change as you go to scale. You may start out very focused in a pilot and then deal with add or change your target populations, and so you need to have an mHealth project that can be flexible to deal with this as it goes to scale. Another is the need for accompanying mHealth projects with champions within the target area, whether that's the population or the community or just the area of focus, that technology by itself will not engender success. You need active champions within that target area. And that good examples of this could be found, say, within mobile technology for agriculture. And along those lines of crossing silos in mobile technology, that mHealth should be open to partnering with mobile technologies efforts for other areas of development, other aspects of ICT for development, so that there can be shared resources for that and shared costs. There also needs to be, one of the solutions that was suggested just overall was better communication and coordination among the mHealth community and among experts, and providing a clearer vision of what we expect mHealth to be, so that it's easier to meet that challenge of what should mHealth look like at scale. And that we need to make sure that people have the proper motivation or incentive in order to share that information and promote that collaboration with each other. A couple key takeaways are to plan for scale from the beginning. It's not something that should occur at the tail end, that from day one you should be planning for scale. To conceive of programs holistically at the systems level, to promote better communication and coordination, build models that can be applied across all health areas as opposed to just one project area, to collaborate to avoid replication of work, to get buy-in from the Ministry of Health at an early stage, and that it may, even if it's financially prohibitive initially, that there must be some added incentive to promote the longevity of the project in the long run, even if that may be difficult at the beginning of a project. And in general, let's stop thinking of mHealth as pilots and start thinking of it as projects for service delivery at scale, and how do we approach that for service delivery at scale already, and how can we start applying that to mHealth? So I would say those are the main takeaways. Thanks for that.
I'll invite Kelly to come back up. We've reserved this time for discussion because we've raised lots and lots of items. I don't know if people have a point that they want to bring up, anything that you still have questions about, would like to hear a little bit more about, but I'll turn the floor over to Kelly. And there's one mic in the middle, and I have one more mic here.
Okay. I'll just go ahead and facilitate then. So if you have a comment, if you can go to that mic, yeah. Yeah, I think it's on.
It's on? Okay. My comment is regarding the use of open source, because the argumentation was, if we use open source, the person might be gone, so it's easier to use a vendor application. And here, I understand a vendor application is more convenient, but on the long term, it's extremely expensive. And a major opportunity when you use open source system or applications is you create in the country a workforce working on that. So you increase your ecosystem and you really start building something, a business environment. And that's a major argument for using open source in developing countries, because there are a lot of open source developers in developing countries.
I think it does. Yes, I think it's a great point, or an interesting thing to discuss. A few years ago, it's probably a little dated, but there was an evaluation done that looked at the costs associated with, and I think it was actually around specifically implementing Windows or something like this. But it compared, a large project where one part of it was implementing Windows, proprietary, off-the-shelf operating system technology, and then they also did an open source, like Linux-based, blah, 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 blah. So they wanted to look at, and they did a very rigorous job of detailing all of the costs. The total cost of ownership, which of course is not just the cost for the software, it's the cost for the support and everything else that goes around actual implementation. And what they found was that it was basically even. Because what happened on the open source side was the capacity issue, was the fact that what actually increased costs on that side was that there weren't, at least at that time, there wasn't a very large pool of people who were actually knowledgeable in open source. And so when they could find those people, they were actually more expensive than the people who knew how to work with the proprietary systems, because the proprietary systems were more popular. So it was like a supply and demand issue, right? Very few open source folks high pay compared to a large base of folks who knew Windows. So anyway, but what I took away from that was that it may actually be the case that in some sense it's a wash in terms of costs. It's just that the cost goes to different places. Windows, your licenses, right, and other fees. But in open source, your cost is going to building capacity. But to your point, if you're doing that, you're building a base, right? And so it's more of like a long-term play. So it's not necessarily that open source is less expensive, but the costs are different. But ultimately, you may be building that local capacity, which is maybe more important.
I also wanted to comment on that as well. And it's pretty consistent with what James said, is that, and I've had that exact experience, the going through those arguments and doing a similar type study. And, it really depends. Again, projects may not really have the incentive, even though they know that by going with local teams who have the open source skills, they're building the local IT industry. But that's not really the objective of the project. So, you have to weigh these things. And unfortunately, this argument about open source versus proprietary gets very religious. And it's not black and white. And most likely, it's both. You're going to use some proprietary and some open source. I mean, one of the clients I've had is Voxiva. They actually have some open source technology in their solution. And so... Oh, of course. I mean, and again, when we talk about sustainability, who is going to, these are the companies that are, when they're in business to make money, they're going to try and provide a solution that actually satisfies the need. So, that's just how business works. So, but what I wanted to say is that it's usually not an either or. It's really what is the solution that solves the problem. And if your objective, if you have criteria that says that you must provide a way to build up local capacity, then you're probably going to weigh open source technology higher than other technologies. It really depends on what your objectives are. And I'd like to reemphasize that total cost of ownership calculation. We did a really fun exercise, and I'm wondering if Carl Brown, and I don't know if Hamish is still here because he was here earlier. We did a really fun exercise at this WHO meeting in Kigali, I think in 2009, to try and bring up these issues and considerations. So we did sort of a spoof or a parody on this. So we wanted to kind of create a little fun exercise where we presented 3 email systems. So we wanted to give them something that wasn't health, because everyone's so married to health and has strong opinions about health IT. So we wanted to take it out of the health realm into something that people are very familiar with. So we said, let's say you are a Ministry of Health, and I think we said in the country of Gowanda instead of Rwanda. So you see, we had some fun with this, and you need to select an email system for your ministry. And you are being presented with 3 proposals. One is Gleemail, which is the cloud-based email system. And I can't remember how we spoofed Outlook. We gave it some kind of name. And then we also had the open source email system. And we had a fake set of criteria that each company was supposed to address. And so we presented how we addressed it. And I took the Gleemail one because having done the consulting with Voxiva, I knew what people's concerns were about outsourcing and a hosted system. So, and then I think Hamish took the open source email system, and Carl took the big vendor email system. And so, unfortunately, I had to leave. I couldn't stay for the next day when they actually went through the exercise, but apparently it was a huge hit. And so we had the participants basically each take on the role of one of those 3 vendors and present and pitch that to a board, the Ministry of Health board, which I think Richard Gakuba was one of the people, and Carl, and I don't remember who else. But they really took it on. They really embraced that exercise. So if that information is still online, it might be kind of fun to share. Because we actually did a total cost of ownership calculation as part of that, too. Well, I think people still went for the open source solution. Even though, when you looked at the cost, I think that it was, I don't think it was the least expensive. I have to, it's been 3 years now, so I'd have to look at it. Anyways, so I just thought it's really, I think we need to take an objective look at it and try and get away from sometimes the religious approach. Oh, I'm sorry. Alice Liu, I'm an independent consultant. I'm consulting for Japaigo right now. Thanks.
Hi, I'm Joy Kamnyari. I work for JSI. I just wanted to add a little something about the open source versus proprietary model. Our country offices in recent years have raised, I guess let me take a step back and say that I think the open source argument doesn't necessarily just come to cost and whether or not it's less expensive to go with a proprietary model or open source, or whether it's a wash financially. The other thing to think about is accessibility. So in recent years, our country offices have said, okay, whether it's mHealth or some other type of technology, we want to go open source. And the reason that they've said this is because they have had situations where they've implemented a proprietary solution like Max, for example, and then something goes wrong. And the closest support is in the UK. These guys are in Zimbabwe, right? They're trying to call the UK. They can't get through to the UK. When they finally get through to the UK, there's the time difference. Then it's a big problem that can't be solved remotely. So what happens? Someone has to be sent from the UK to Zimbabwe. That's not going to happen tomorrow. It's going to be another couple of weeks before someone is able to come and actually support the system and fix whatever the problem is. And so they have come to us and said very strongly, we don't want to have to do that. We don't want to have to deal with that. So even if open source turns out to be more expensive at the outset. The point is, if you build the capacity in country for people to be able to support that, then they don't have to go to South Africa, to the UK, to the US to get support for these systems. They can just work with someone in country who has learned how to support the system and who can give them the support they need as soon as they need it without having to go through this long queue and the long time lag. Thanks.
The analogy I like to give is when you move to open source, you give a safe to the company, but you also give them the key. If you go proprietary, you give them a safe, but they don't have the key. And we worked, with InfoDev on the Y2K initiative, the famous bug, and we worked worldwide, and the major issue was all those governments completely trapped into those proprietary software, and very often given by donors. So it's a long-term issue. The cost may not be the major issue, but on the long term, I think we are building more capacity and more flexibility and more freedom.
So let me ask a question. This is a fabulous discussion, and I'm just wondering, is there a matrix that takes into account the various considerations around open source versus proprietary with project goals? Is anyone aware of a decision-making tool that exists to address that?
There are some examples. For example, GSA. The
GSMA?
The group in the U.S. government that GSA that takes into account all the contract. GAO? Yeah, I think it's GSA. Anyway, they are the ones who are really looking at the contracts for all of the agencies in the government. They moved to open source. And they are the ones who are counting all the pennies in the government. So, it's well documented, and their upfront costs were much higher. But in 3 years, they recoup that. Okay. So, and there is also the UK education project when Tony Blair gave a huge amount of money to all secondary schools to go and to have access to the internet. And it's a very interesting project because it was over 5 years, extremely well funded, and they created a specific group for the evaluation that started from the beginning. And it's called BECTA, B-E-C-T-A. It's probably online. And what was very interesting, talking with the directors of the different schools, they all choose, 90% of them choose a Windows environment. And after 5 years, they were pretty upset because they were not able to upgrade what they needed. And true, in an education setting, you need to change the content of your class. The keys are not the same. Right. You have curricula changing. So they were really trapped. And they didn't have enough funding to pay the vendor to change their system. So that's 2 examples.
Okay, thank you, yeah.
Just to add, so the study that I was referencing was done by a group called GESI, G-E-S-C-I, I forget what it stands for. Anyone know about it? Sounds familiar, but I don't know. It's not education, it's actually health. It's ICT and education, but I just Googled GESI, TCO, evaluation, and I got a link to a website where there are a set of tools for around calculating sort of total cost of ownership, specifically with regard to ICT and education, but I think the basic kind of buckets of costing that they're looking at will be exactly what we need to look at.
Okay. Tamaji also has who is open source. Tamaji has a costing tool.
Very great.
Further solution. This is a little broader than what we're looking at, regardless of the technology.
Thank you. Send it to Laura.
I was just going to add, for that paper I did, it was actually for Rockefeller and Voxiva, there were some source materials, and I think there was a paper from the Australian government on, I think targeted at the IT professionals in the Australian government about making that selection. And so that's an older paper now, and there may be a more recent version, but I can dig it up. And I know when I was doing the total cost of ownership calculation for Voxiva, and so in their case, their major challenge was governments not wanting to go with an outsourced system, which of course 4 years later now, people are going with cloud. Right? Nobody's objecting to Datadyne, right? Nobody's objecting to EpiSurveyor or anything else. So it's changed a lot. But I know one of the models I took, and I think James is probably bringing up a really good one. And I looked at I think some studies in the Information Week. So it was a study of looking at Salesforce.com versus another system. So I think sounds like there's 3 or 4 potential sources here where you can come up with your own costing model and do your own comparison. And you can just kind of borrow the best of all of these.
This is all fabulous, and let me just say that, one of the goals really of this mHealth implementation guide is really to provide links to these resources, right? And so please, I know we talked about this in the roundtables, right? And that's why we had this question C, because we really want to create a place where it's user-friendly for people to go to these resources when these are the challenges that you're confronted with, right? So if other folks have other ideas for resources or resources that you haven't heard talked about yet, if you would send them our way, we would be highly appreciative, and we'll give those back in the form of this web-based guide so that we're quickly pointing people to the resources that they need. So thank everyone. Thank you all.
I just wanted to make one last comment around, I think, the vendor lock-in question, because you can also have a staff lock-in, right? When there's only that one person in IT who can fix a problem for you or do a report for you, do an enhancement, but they're busy with other projects or they're on vacation or they're out sick. So there's lock-in in different areas that you also have to look at when you're evaluating these.
So I think sorry, let me interrupt for a second. I think we'll have another, 10 minutes of discussion and then wrap it up, right? Because I know it's been a long day for everyone. And so that was a really wonderful conversation. I wonder if we want to transition now to a different conversation. Kelly, are you going to transition us to?
I'd like to take advantage of a segue. And the comment that JSI made about the fact that open source wasn't merely a technological issue, it was also a matter of having accessible capacity, where do you find staff that can work with a project, whether it's open source or otherwise, afterwards. And this touches on what was a little bit of a surprising direction for the sustainability group and what they reported. And that so often sustainability is treated merely as financial sustainability. And this is certainly a very important issue and opportunity in mHealth. But a lot of times it's framed that way because of who's sponsoring the conference. There's also, sustainability is not a new issue in global health, and it's often thought of more as local capacity. And I went to a discussion today on capacity building, and it made me realize what different ideas there are about the definition of capacity building between those on the IT or mobile technology side and those on the global health side. And so I'd be interested to hear, if I could kind of segue into a different discussion topic, what people think about building capacity in mHealth, because this is something that I heard come up and mentions in various of these issues, and I think it's something that might be, in effect, cross-cutting in how it affects all of these issues. It was certainly an issue that came up for us in Scale Up. So I'll do that more as an introduction if someone wants to follow up on that. If not, introduce something else.
Hi, I'm Bill Lester from MPOCI. This issue of sustainability and capacity building came up in our sustainability group. And I suggested that there are some lessons learned and best practices that already exist from previous technology implementations in the past. And the one that I'm familiar with and actually still involved with started in the 90s when our international NGOs and their field offices tried to incorporate basic computers into the work they were doing. And the challenge then was to get computers onto the desktop at our field offices and to get the staff with the skills to actually use those computers, and the programs on them like Office, like Excel and Word and whatever, to help in our programmatic work. And the model that started out was to fly people from the U.S. over to the field offices to carrying the computers with them and put it on the desktops and then train the staff and then leave, only to find out a week later or a month later there were problems, and then fly them back. And it was a very unsustainable, very expensive solution. And so the community came up with this idea that evolved from some local capacity building in the U.S. At the time, it was called circuit writing. And these were nonprofit tech people who went from small nonprofit to small nonprofit, helping to train staff and to work on the computers. And they took that model, they reworked it, and they called it e-writing. And the idea was you would go to a country like Kenya, you take a local capacity group of IT graduates or whatever, and teach them how to support the nonprofit community and to work around and share the cost going from place to place. So that was fairly successful in a lot of countries. But once you got the computers on the desktop, the question was, well, what do you do with those computers? How do you use the programs? And so what developed was something called iWriting, information writing. Writing is R-I-D-I-N-G. And information writing was not tech people, it was content experts. People, for instance, let's say you were using a financial management system like QuickBooks in the field. These were QuickBooks experts who went from place to place to teach the little field offices how to use QuickBooks effectively to manage their projects, or how to use EpiSurveyor, or how to use whatever the tool was. Again, local people, local capacity. And so building e-writing and iWriting programs can easily be translated to supporting mHealth, both in the technology, the actual mobile device, and in the applications that they're supporting. So if you're promoting an mHealth solution that you want to put out there, and you're thinking about how do I build capacity, how do I build sustainability, you want to build capacity not just in the ability to use the application, but how do you actually teach and empower and build a staff buy-in? And these e-writers and iWriters learn skills beyond just the technology or just the application to learn how to engage groups or communities in buying into the application. I just think it's a really good opportunity to take something that already exists. There's lots of training materials out there. My organization does trainings in this, but there are others as well, and repurpose it for this whole new requirement and need.
So I'm just going to be a little bit provocative, which is I'm hearing a lot of talk about sustaining and scaling up a technology. And I'm not hearing a lot of discussion about under which circumstances it's appropriate to be using this technology. I mean, I think we'd all probably agree that mHealth is about helping to leverage better outcomes when it comes to health outcomes for clients and stronger healthcare systems. And I liked the way Kelly, had the client centered and the health systems in terms of different mHealth applications. But I guess I'm sitting here thinking, well, why would you plan to scale something up if you haven't even really evaluated it? Why would you plan to sustain it? And so I guess I want to be a little bit provocative and say, what I'm really struggling with and trying to understand is, for those of us who work in public health, where is it most appropriate and where does mHealth as a technology bring, very important value to our work? We're struggling to answer that question in the U.S. I mean, it's an active point of debate. I work domestically and globally. I don't think any of us really have an answer to this. So I guess I would just like to sort of maybe make a suggestion that we're a little bit more modest before we start talking about scaling up and sustaining, and that we have a clearer picture and consensus around where, particularly in this global health discussion, in low resource settings, mHealth is our powerful tool for what? And that's what just makes me a little bit sort of uncomfortable, because there's a lot of money that can be poured into this. And I think for those of us who have worked over many years in, very low resource settings, there's no magic fix here. And the tool is only going to be as powerful as we make it in the context of an understanding of how it can help us to, push those outcomes to a different place. So sorry, but I'm sort of a bit outside the field, but I'm just giving my sort of fresh perspective here.
Thank you, and I will say that that's also, I think it's Kathleen, is that right? So yes, so Kathleen, you also just highlighted one of those. We have 5 issues that are we feel like are so challenging for mHealth implementers. We began with one with the vote with your feet, right? Should clients pay for services or not? Y'all identified another one just now in the discussion around open source or proprietary. A third point you just also highlighted, which is, do you design for scale or not? And I think one of the things I heard from the report out from the Scale Up Roundtable was that you should design for scale. But I think that's a really important point. just to throw out to you, so thank you. You all have identified 3 of the 5 that we have said we feel like these are the big issues. So I thought that was an interesting tension if anyone wants to.
Well, I would like to share actually one project which I'm working on currently. My name is Youngji-jo. I'm a PhD student at Bloomberg School of Public Health. I had a privileged opportunity last summer working at WHO for mHealth costing studies. And at the time, we were kind of developing some very generic but kind of very generalizable total cost ownership, which actually have amended from the Dimagi's TCO table. So we kind of have developed a kind of a preliminary table. And we have tested for the cell life case first, and then has been well received. So actually last week I had a trip to India for a week visiting Dimagi and focusing on one successful case, which is Dimagi Save the Children, and then IHAT in Rajasthan state that they have successfully scaled up to 70 ashas. And that has been finished last September, but they are kind of looking for next funding. But I'm kind of communicating, working with the partners currently to capture some cost information, and we kind of fill up in the amended TCO table, and then produce some cost profile, trend, and cost saving strategies, and total cost, of course. But the reason I'm kind of sharing this thing is we are interested, to apply this tool to multiple different mHealth strategies or mHealth project. So far, we have tested to Cell Life as a one kind of B2C case, like a business to consumer case using the text message. And then the Dimagi case was an interesting case using, particularly focusing on community healthcare intervention on maternal and newborn child. But I believe that there are other various, type of mHealth project on focusing on nutrition or immunization or things like that. And maybe next year, if this study going well, then we are interested in incorporating other projects. So just to let me know if any of your organization are willing to share your budget, information or cost information, then we want to expand this opportunity. Thank you.
Thank you for sharing that. Thank you.
Thank you. I've been to a couple of the sessions, and people talk about scaling up. And we all know that this is mobile health, and it can go anywhere. My problem is getting people data, whereby we talk about confidentiality. How are we sure that the data that our clients give us, we ensure that it is protected? For me, we work with a service provider that, of course, we've told them about the fact that FHI 360, we are very particular about the confidentiality of our clients, but you cannot really tell who knows whose telephone number, So how do we protect? My concern is, as we scale up across the world, how do we ensure that confidentiality of our clients are protected?
Could you please introduce yourself?
I'm Siadi Otogbenu. I work with FHI 360 in Ghana. I'm the officer in charge of our mobile health project. Thank you.
I'm the party crasher of the group. I think the team knows that. I'm Bruce Bowers. I'm an independent consultant. I walked by the door and saw that this was probably the best sessions going on because of the activity going on, so I came in. How's that for honesty? My last 5 years have been spent with MedApps, a company that provides telehealth products and services. They were purchased by Alere, so I feel like I'm a successful businessman now. So we have some merit there. I've heard a lot of things. I learned a lot today about donor versus company, ROI versus donation money. So donation's completely foreign to me. I've never done it. I've never worked in it. So I didn't really understand some of the concepts to begin with. So, when I talked about a business plan being very solid and well done, it was against the grain because, and a good point was the donation served the purpose. So I learned, from that. When it comes to security, what we did to provide security was every message that was transmitted was de-identified by a number, so no person's name, address, or information was well known. So we de-identified. The system and technology we used was encrypted, so we had encrypted messages, and we also had technology in the hardware and the software. So if you can de-identify any message that's sent, you should be able to be familiar with just a few people on the sending side and the receiving side to be able to have it controlled. Then you de-identify any instruction or any information. If a hacker got in, they would have a number plus a bunch of numbers. So it's one way that's possible for you. So I wanted to answer her question. Okay. If you de-identify the message, even the telecom operator cannot find it because it's embedded in your system, not theirs. Yes.
Actually, we don't have problems with that because we ensure that the telephone numbers that we have in our system, there are no names to it. So it's very difficult for somebody to really track. Like when you talk about those who provide service and the health facilities, whereby they have to put people's names and telephone numbers and other particulars, whether you're HIV positive or you are not, to enable other health workers to access. I'm sure that in the process, my data is not something. That's my concern. But
Yeah. If it's human, yeah, even our system, if human intervention, someone told somebody the information, then it is encroached. I have no answer to that. Yeah.
My name is Magnus Conte, and I work for World Vision Ireland. And I'm part of the team that is introducing mobile health technology in Sierra Leone, one of our projects, the Child and Maternal Health Project. I just wanted to say that one of the things that we have done from the very start of our discussions around developing this solution was to involve and engage with the telecom regulator from the very beginning. And they have huge experience and expertise in terms of data protection and some of the issues and potential challenges that you will encounter going forward. And they would usually provide technical support and advice in terms of what sort of guidance and protection you need to put in place as you collect this data and you engage with the service providers. Because the telecom regulators usually license the telecom service providers, and they understand some of the data protection issues that need to be considered. So it's advisable at the very beginning to engage with the telecom regulator, but also to engage with the Ministry of Health, as they also have issues around confidentiality and how the data needs to be protected. And I believe that if you have these engagements at a very early stage, it will help you to address some of these issues. It may not entirely eliminate it because there's human error. It always happens. I mean, with the best systems in the world, you have all sorts of things that could go wrong. So I just wanted to share.
That's an excellent suggestion. That's an excellent suggestion. So thank you. I'm sure many of us in the room appreciate that. So I'm thinking that maybe it's about time to wrap up, unless there are any burning comments people want to make. Anyone? Yes, James.
You shouldn't always design for
Yes. So we raised a lot of questions today. You all raised a lot of questions today. We don't have a lot of the answers. In fact, I feel like we have way fewer answers than we have outstanding questions. So thank you for everyone for coming and participating and sharing your expertise. You want to talk now?
No, it's just the last question for you. I think all the groups
I'm trying.
emails.
Yes.
I don't know if that's the same for all the groups. And there was also a note taker in all of the groups. Is it
Yes.
possible to send all of the notes
Yes. So if you did not give your business card to the note taker in your group, please go ahead and bring it to Laura. Okay, because what we're going to do is to actually do a very nice job of documenting all the different conversations that were going on, and we will redistribute it back to all the participants at the meeting whose business cards we actually have.
Should we just sign them up for the mHealth working group?
Yes.
Should we just sign you up for the working group? Yes.
Okay, so everyone's cool with that? Yes.
Also, just thanks very much to everyone who organized this. I think it was really, really helpful. And I don't know if the organizers of the actual summit are listening, but if we could have more kind of sessions like this next year instead of listening to the same, more or less the same people talk about the same things.
Wait a minute, you mean just sitting right here doesn't make me an expert?
Yes, thank you. It's really nice to have more of these, so I don't know who's going to pass that message forward.
So Bill wants to say something. Hang on.
Maybe we can get the organizers of the mHealth Summit to do evaluations of their sessions. None of us in our organization would think of doing this without having to evaluate.
So are we going to take this to scale?
Are we going to take this to scale? Good. So if you weren't in a small group, bring us your business card because we don't have it.
Okay. All right. Fabulous. Thank all of you. I mean, this only works because everyone here is participating and is sharing their own experiences and questions around this. So again, just to reiterate, if you didn't give your business card in your small group, please go ahead and bring it up here. We will recirculate this back to all of you for the mHealth working group. I want to just two last things that I want to say. I got to choose the quotes because I got to put the slides together, and so I really like this. So quality is never an accident; it's always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives, and that's mostly true. Sometimes things are huge successes in scale on their own, and they're kind of shots in the dark, but generally we have to really do our homework and work really hard at what we do and have a game plan for it. And so what we're really trying to do is really to support everyone's game plan so that we can have the biggest impact, positive impact on health and development across the world. So I just wanted to say it's great to have a roadmap. And then the last thing I wanted to say is that this has also been, I think, particularly helpful because as we've been trying to kind of create some kind of global guidance around mHealth implementation specifically, we have kind of stepped back and said, okay, we're going to stop with what we can. We're going to take at a point in time, and we're going to say, okay, we're going to figure out lessons learned at this point and try and disseminate them globally. They're not perfect. The end-all lessons out there. We don't have all the answers. Like I said, more questions than answers, but we're doing our best to get information that we can out to the global mHealth community as quickly as possible with the recognition that it's not the final word and it's not perfect. And so I would encourage everyone else to do that too because, mHealth is it's moving at lightning speed. And so it's really incumbent upon us to really figure out how to do the best job that we can for the resources we're given and for public health and development in general. And so one thing I've learned a lot from you all today, listening to everyone, is that HIP draft that we handed out, and I think also some people didn't get that, and so we'll also circulate that too. A lot of the lessons learned from there and that I presented in the slides today, we're hearing those, they're being echoed from you all, and that's really important and that's really helpful because y'all are talking about the issues that we've been trying to pull out and to provide what we have right now for guidance around those issues. And so I just want to say thank you to everyone because I think we're hitting the right issues. And so we really appreciate just that feedback and that kind of ground truthing or face validity that you're providing to our efforts to gather what we do know and disseminate it back. So thank you, everybody.
Thank you.